bring them in primary prevention, age 0 to 19, age 20 to 39, age 40 to 75, and they are further classified according to LDL level. Like if their baseline LDL is greater than 190, which is most of the time in familial dyslipidemia. So they are considered in this separate group, that where you need high intensity therapy as a class 1 indication. Then patients with diabetes, they need moderate intensity. But with diabetes and having additional risk, again, high intensity statin therapy. And age greater than 75, clinical assessment and risk reduction. So previously, primary prevention was divided among patients with diabetes, without diabetes, baseline greater than 190 LDL. And according to that, usually target were in without diabetic, it was less than 100 LDL, and with diabetes, it was less than 70 to achieve. But we'll see in the newer guidelines, and these were the modalities of treatment or decision to make regarding treatment according to their risk status and LDL levels. Then they have added few more things into it in assessing risk of patient. ACVD risk and answer, I tell them in a separate slide as well. And then calcium scoring is also jumped in to assess patients' risk status to decide about LDL target. This was the risk calculator. We put in different variable and calculate patient risk of having ischemic heart disease event in next 10 years. Usually the features or variables are sex, age, race, total cholesterol, LDL, systolic blood pressure, diabetes or smoking. So the conventional risk factor, as much risk factor you have more risk of developing IHD events in future. These were the risk enhancer considered in that guideline, that family history of premature, persistent elevated LDL level, CKD, metabolic syndrome, conditions specific to women, preeclampsia, premature menopause, inflammatory disease can serve as a precursors to having ischemic heart disease and events, and ethnicity, especially South Asian ancestry. Lipid levels like persistently elevated triglyceride levels, then added things, CRP level, LP little a, apoprotein B, ankle brachial index, and we'll see in the newer guidelines, it is indicated, especially if your patient's LDLs are normal, at least to check once in a lifetime ApoB and lipoprotein A as well. And this was regarding calcium scoring, that especially in patients with greater than 40 years, LDL greater than 70, without diabetes, having an intermediate risk with like positive family history, you are considering that this patient may need statin, this risk, you can do calcium scoring, and if it's clearly 0, you don't have to give statin. 1 to 99 CAC angstrom that favors statin, greater than 100, it is an indication to start statin even in this primary prevention. So a good tool to assess risk in borderline patients when you are undecided about patient risk to assess with calcium. Secondary prevention, even in this guideline, they started having consideration in terms of high risk and low risk, or extreme high risk or high risk. In that way, they have decided different LDL levels, and just to include the features definition for very high risk atherosclerotic. Previously, we keep all atherosclerotic cardiovascular disease patients in a single group, but with this guideline, they started having division, even those in atherosclerotic cardiovascular disease group, very high risk or high risk. So this was one major event, recent ACS within 12 months, history of MI, history of ischemic stroke, symptomatic peripheral artery disease. So even in atherosclerotic cardiovascular group, you have to pick very high or extremely high risk patient to get to the target in a way that These were the target at that moment. LDL-C less than 30, 130 for low risk. So एक नॉर्मल आदमी हम जैसे जिनमें रिस्क बहुत ज़्यादा नहीं है प्राइमरी प्रिवेंशन के लिए, so your target of LDL at that moment was less than 130. With moderate risk less than 100, high risk less than 100, very high risk less than 70, and extreme high risk less than 55. Most of the time, patients with atherosclerotic disease, with multiple events, additional risk factors are coming into that extreme high risk group. And just above them are also having a very strict target, which are very high risk, less than 70, even at that moment. Now you see just ESC updated guidelines regarding targets and classification of patients. They have kept very high risk atherosclerotic cardiovascular, either clinical